In this lecture, I'm going to talk about psoriasis. And psoriasis, it is chronic inflammatory dermatosis. And as you may know that about 80 to 90% of people with psoriasis have raised skin plaque. So this lesion, it could be raised, but however here, as can be seen here, these are silver scales or patches. So here we call it plaque psoriasis, but however in this lecture we are going to speak or to talk about psoriasis in general. And psoriasis is a chronic disease or disorder in which the immune system becomes overactive, and this actually causes skin cells or keratinocytes to proliferate and to multiply too quickly. And psoriasis may be associated with several diseases or disorders, for example, arthritis, myopathy, enteropathy. But however, in this lecture, we are going to focus on psoriasis alone, or psoriasis with arthritis, or arthritis as a manifestation of psoriasis. So, clinically, psoriasis most frequently affects the skin of elbow, as can be seen here. This is the elbow, and also in knees. We have no here photo for that, and also can affect the scalp and lumbosacral areas, and intergluteal, cleft, and glans penis. So the most typical lesion is a well-demarcated pink salmon colored, and if it is raised, so we call it plaque psoriasis, and as it is covered, as can be seen here in this photo adapted from this address. So this lesion is covered by a loosely adherent scales that are characteristically, as can be seen here, it is silver white in color. So there is a genetic association or link to genetic, and as I mentioned before, that most of immune mediated or autoimmune disorders, they are it is not actually a single factor responsible for autoimmune or immune mediated disorder, but it is constellation of constellation means more than one factor. One of them is a genetic predisposition, and the other one is a trigger, and the trigger usually these are environmental factor. So there is an association between psoriasis and HLA-C, but however recently it has been shown that also there is an association between psoriasis and HLA-B. So when HLA-C and HLA-B association with psoriasis, usually it is associated with arthritis. However, despite this association, only 10% in individuals that carry these genes, they get psoriasis. And as can be seen here, in case of psoriasis, a patient may present with skin lesion and articular lesion, or may present just with arthritis without an skin lesion. So here in psoriatic arthritis, the synovial condition is altered and characterized by increased vascularization. This due to fact that psoriasis is cell mediated, and actually some growth factor or vascular growth factor, vascular endothelial growth factors, they are expressed together with other cytokines. So the joint in case of psoriasis, actually it is characterized by increased vascularization, proliferation of fibroblasts, and infiltration of innate cells. For example, dendritic cells and macrophages infiltrate here, and also there is an infiltration of T and B cell, and as you know that it is strictly forbidden for all these cells to come and to settle and to sit here in the joint. But however, due to this genetic association, and maybe due to another trigger factor, so these cells, they find their way to the joint, and so the infiltrated lymphocytes produce growth factor for keratinocytes of the skin. So this lead to hyper proliferation of keratinocyte, and as can be seen here, there is much evidence that TNF is a major mediator in the pathogenesis of psoriasis. So, however, we know that recently that other cytokines also are implicated in pathogenesis. For example, interleukin number 17, interleukin number 23, interleukin number 22. So many cytokines now are involved in pathogenesis of psoriasis. So neutrophils. Also, neutrophils take a very big part and play very crucial role in pathogenesis of psoriasis. And as can be seen here, this is actually a neutrophil. They present in keratinocytes. They infiltrate the keratinocytes, and they modify their chromatin, and they send out some filaments. This, it looks like a trap, and these filaments are very sticky, and they are equipped or weaponed with other materials. For example, reactive oxygen species, and maybe interleukin number 6, which is a pro-inflammatory cytokines, and myeloperoxidase, and granules. All these may lead to deterioration of the disease. So recent reports indicated that oxidative stress, granular components, and neutrophil extracellular traps from psoriatic neutrophils, these actually isolated from patients with psoriasis, they are related to the initial and maintenance of phase of psoriasis. And actually, neutrophils, they have the capacity to phagocytose these filaments, but however, these filaments, they trap maybe crust or dry materials, or maybe they have the capacity to trap microbes at the area, and also they trap platelets, and this may initiate formation of the thrombus in the area where they are present. So in case of psoriatic arthritis, as I mentioned, that there is a genetic association. Usually it is when there is an arthritis, it is HLA-B and HLA-C. So in psoriatic arthritis, the synovial, as I mentioned, that it is with increased vascularization is increased in this, and there is cells, they come and sit here inside the joint and lead to inflammation. And as can be seen here, that dendritic cell play a major role in the arthritis due to psoriasis, and actually these dendritic cells, they activated by different stimuli, and they produce interleukin number 23, interleukin 12. Further, they produce further these cytokines stimulate T helper number 17, gamma delta cells, and T helper 1 respectively, and this lead to production of inflammatory cytokines. And these inflammatory cytokines actually, they lead to inflammation seen in the plaques, or in case of psoriasis. So here, before actually coming to this, I would like to show one slide here. It is regarding the immunotherapy, but let us now go to this cellular infiltration and these cytokines. Now new medications or new drugs for psoriasis, they are actually just antagonists for these cytokines. For example, tumor necrosis factor alpha. We know that tumor necrosis factor alpha, it can induce destruction of tissues or keratinocytes. So now there is an injection against TNF alpha known as Infliximab, just to stop the destructive effect of TNF alpha on keratinocytes. And also now we have a new medicines or medications in the market, and they are in use. For example, IL-17 antagonist, and actually these, they come from the lymphocytes. As I mentioned, that there is an infiltration by lymphocyte. So let us now come to the therapy for psoriasis. So recently there is a drug or a treatment or a medication. It is known as Bimekizumab. Bimekizumab, this is actually, it is anti-IL or anti-interleukin number 17. And this interleukin number 17, it plays a crucial role actually as a pro-inflammatory factor, and induces inflammation with hyperkeratosis. However, during this inflammation, keratinocytes, they produce other chemokines, for example, interleukin number 8, and some vascular stimulatory growth factors that induce angiogenesis. So now in the market, there is a new drug or medicine known as Bimekizumab. Bimekizumab or Bimzelx. It is actually very effective in case of psoriasis, especially if it is associated with arthritis. And as I mentioned that actually TNF alpha, actually it comes from many cells. For example, we have macrophages, or we have M dendritic cells. So dendritic cell, some dendritic cells, they are very similar to macrophages, and as I mentioned that dendritic cells, they come and infiltrate the keratinocytes, and they play a very crucial role in the pathogenesis of psoriasis. So now it is available in the market, and injections known as Infliximab. This Infliximab, it is anti-tumor necrosis factor alpha. But however, these injections, Infliximab, they bring the tumor necrosis factor alpha to a physiological level, as it is in the pathological level. So it is increased. We call this a pathological level. So this we use it with actually cautious, because TNF, this cytokine, plays also crucial role for defending us against viral infection, parasitic infection, bacterial infection. So just the aim of the treatment with Infliximab is to suppress these cytokines, and to suppress the cells, and to bring the TNF to a physiological level. And also nowadays tablets available. These are mycophenolate, and these mycophenolate tablets, it is widely used nowadays as an immune suppressant, and this could be a therapeutic option for psoriasis patient. However, there are other treatment for severe cases. For example, also we can give methotrexate, but however, methotrexate, this treatment, it has some side effects, so we should give together, to reduce this side effect, together with methotrexate, we should give folic acid tablets. Thank you very much, Professor Ahmed Bolad.